morning. At the outset, I take this opportunity to thank the organizers of International Symposium on Hepatitis E virus 2010 for inviting me for this talk on a disease which is so important to us in Kashmir, India. In the next 20 minutes, I shall present to this august gathering how I saw the 30 years of hepatitis E since I recognized it as a disease during an unprecedented epidemic which hit Kashmir Valley in November of 1978. I've been given the task of unfolding the mystery of hepatitis E virus infection among pregnant women in hyperendemic region, namely Kashmir Valley, and I shall attempt to bring knowledge related to this subject. Quite a bit has been written about the history of hepatitis E. I thought this may be an ideal form to uncover my personal untold story of how I recognized the first ever recorded epidemic of hepatitis E and on what basis I proposed it as a new and yet unknown disease and asked the international fraternity to look for a new agent. In late 70s, during my fellowship in gastroenterology, it struck me that emergency room and intensive care units of the hospital I was working was always occupied by a considerable proportion by pregnant women with liver disease, with high mortality, and autopsies of fetal patients uniformly revealed massive hepatic necrosis as a cause of fulminant hepatic failure. Late Professor D.V. Datta would often call me on a cup of coffee after the morning meeting and ask me on each session, "Sultan, why do these pregnant women come and die?" He knew that I did not know the answer and possibly wished me to find one. It's unfortunate that even after 30 years of his question as to why pregnant women in India suffer from hepatitis E, develop fulminant hepatic failure, and die remains unanswered. With these ideas ingrained in my mind, I went back to Kashmir in June of 1978 to establish a clinical unit of gastroenterology at the Medical College, Srinagar, Kashmir. A simple phone call on a cold morning of November 1978 changed my course of work in Kashmir. I was told that in and around a town which is 50 kilometers from the summer capital of Kashmir, that's namely Srinagar, there was a huge commotion caused by an epidemic of jaundice, and pregnant women are hit the worst, and many of these women have already died. Tour of the region next morning revealed no less than a mini tsunami state of affairs. Over 200 villages with a population of 600,000 were hit by the disease. In the next 2 days, we were organized to start a house-to-house survey of the villages, and through the service of 500 healthcare workers, recorded and studied each and every new case of jaundice. Since then, the surveillance hepatitis team has done remarkable to do house-to-house surveys of all the epidemics which have hit Kashmir till now, reported on sporadic hepatitis cases from various affected districts, and did follow-up surveys on the antibody prevalence of the population affected by the epidemics. I must mention the region involved by the disease had extreme weather conditions and most primitive healthcare facilities, and it was extremely hard to do field studies under these trying situations. Also, the laboratory facilities were non-existent, and we had to get an outreach support for serological testing for hepatitis A test just available by that time in few research laboratories. Intensive house-to-house field study of this epidemic and careful analysis of the epidemiological, clinical, biochemical, and liver histology findings, and 18 months follow-up of the ICTR cases revealed data which were unbelievable and unprecedented. The disease had caused colossal human suffering and loss of life, and an estimated 52,000 patients had developed icteric hepatitis with over 1,700 deaths. The disease had unique clinical and epidemiological features. Most remarkable was increased incidence and severity of disease in pregnant women. In fact, by the time the epidemic had subsided, most of the women in late pregnancies had died. The disease was self-limiting and did not cause chronic liver disease. Based on the above, I was convinced that this disease did not represent hepatitis A as described in the West and should be caused by another enteric agent not yet described in literature. Testing of acute phase sera confirmed our belief. These data that a new form of hepatitis virus caused this epidemic were presented to the annual meeting of the Indian Society of Gastroenterology in 1979 at Pune, India, and subsequently widely communicated. These data were received with great interest by the international scientific community, and a short plenary session presentation delivered by me on epidemic non-A non-B hepatitis at the first international conference on viral hepatitis held in New York, United States, chaired by Dr. Blumberg and Dr. Saul Krugman, is the testimony to that. However, this report was not without skepticism from some international experts who believed that this was a classical epidemic of hepatitis A and hepatitis A testing was faulty. I surrendered thousands of sera to many international laboratories only to confirm that these sera lacked acute markers of hepatitis A virus infection. Recognize the innovative nature of this study. The article on epidemic non-A non-B hepatitis has been included in the book on history of viral hepatitis edited by Lay and Thomas, 1988. Very soon after the description of the Kashmir epidemic, Wong et al. Procured paired sera stored at the National Institute of Virology, Pune, India, from an epidemic of acute viral hepatitis which had occurred in Delhi, India in 1955-56 and had caused an estimated 29,300 cases of ectopic hepatitis. This epidemic had been studied by the Indian Council of Medical Research, India, and was reported as a classical example of hepatitis A. All sera, when tested retrospectively, were found negative for acute markers of hepatitis A, confirming that this epidemic was non-A, non-B type. I believe it's unfair to claim this epidemic as the first recorded epidemic of hepatitis C in literature. In fact, this report published by the SMR did some disservice to the knowledge of hepatitis E, as it was believed to represent a classical hepatitis A epidemic in the literature for over 25 years. Thoughtful analysis of the data should have arisen suspicion of an alternative enteric viral agent, and animal transmission studies should have been performed in late 60s. In late 50s and 60s, a number of epidemics of jaundice from Indian subcontinent were reported in the literature. These epidemics had epidemiological features resembling the Kashmir epidemic. Similar epidemics of jaundice had occurred in Europe and the United States in 18th and 19th century. None of these epidemics has been tested for acute markers of hepatitis A due to lack of availability of sera. These data point to the fact that epidemic hepatitis E is an ancient disease and has recently become restricted to developing countries with unsafe water supply and poor sewage disposal. Severe liver disease in pregnancy during epidemic due viral hepatitis in Indian subcontinent has been described for long. However, these data were looked with great skepticism in the West, as these data were analyzed from inpatient populations or poorly collected field data, as in the case of Delhi epidemic. We for the first time conducted a prospective field study during an epidemic of non-A non-B hepatitis to determine the incidence and severity of hepatitis in pregnancy. Disease occurred in 36 of the 208 pregnant women, that's nearly 17.3%, as against 71 of 3,350 non-pregnant women, that's 2.1%, and 107 of the 3,822 men, that's 2.8%. Thus, incidence of disease was significantly higher in pregnant women than in the two control groups. The incidence of viral hepatitis in the first, second, and third trimester was 8.8%, 19.4%, and 18.6% respectively. Thus, incidence of disease was higher in all the 3 trimesters to that in non-pregnant women. Fulminant hepatic failure occurred in 8, that's 22.2% pregnant women with viral hepatitis as compared with 3, that's 2.8% men, and no non-pregnant women. This significantly increased incidence of fulminant hepatic failure was indicative of greater severity of hepatitis in pregnancy. In fact, deaths in pregnant women during epidemics of hepatitis E were the most challenging problem for healthcare delivery in the developing countries. In 2003, we reported on a prospective study of 76 pregnant women and 337 non-pregnant women of childbearing age with acute sporadic viral hepatitis. 65, that's 80.5% pregnant women had hepatitis E as against 41.5% non-pregnant women. 1/3 hepatitis E patients were pregnant as against 5% non-hepatitis E patients. The prevalence of hepatitis E virus infection was higher in all 3 trimesters. Fulminant hepatic failure occurred in 45, that's 76% of 76 pregnant women with viral hepatitis as against 34, that's only 10% in non-pregnant women with viral hepatitis. 45 pregnant women with hepatitis E virus infection had fulminant disease as against 14 of the 140 non-pregnant women with hepatitis E virus infection. Thus, increased prevalence and severity of sporadic hepatitis E virus infection in pregnant women resembled data collected during epidemics of hepatitis E, and again a challenging healthcare problem in such regions. Thus, one of the most distinctive features of hepatitis E virus infection was increased incidence and severity in pregnant women. During epidemics, incidence of disease is 8 times more and mortality 15 times more in pregnant women than in the control groups. Deaths in the 3rd trimester is astonishingly 44.4%. In sporadic infections, rate of fulminant hepatic failure in pregnant women is 69.2% as against 10% controls. The cause of increased incidence and severity of hepatitis E virus infection in pregnant women remains unknown. Data from All India Institute, New Delhi, on acute liver disease during pregnancy in India, published in Hepatology 2008, under provocative title, "Is Prognosis Really Worse?", has created misunderstanding on relationship of hepatitis E virus infection in pregnant women in the Indian subcontinent. In this article, projected in this slide, I have depicted the prognosis of acute liver failure during pregnancy from Kashmir, published in Journal of Viral Hepatitis in 2003. Of the 180 patients with acute liver failure studied prospectively, 79 patients had hepatitis E virus infection and 110 patients had non-E etiology. 41 of the hepatitis E induced liver disease died as against 90 of non-E acute liver failure. Thus, prognosis of hepatitis E virus induced acute liver failure was better than non-E related acute liver failure. In a multivariant analysis, we showed that early predictors of poor prognosis for acute liver failure in Kashmir were non-E etiology, prothrombin time more than 30 seconds, grade of coma more than 2, and age more than 40 years. Pregnancy per se, or duration of pregnancy, did not influence the mortality of acute liver failure in this study. 47 of the 49 pregnant women with acute liver failure had hepatitis E virus infection. In this group, 25 patients died. These data may seem surprising in view of the earlier data, which showed increased incidence of severity of hepatitis E virus infection in pregnancy. However, the fact that pregnant women have increased acquisition of acute liver does not necessarily mean a higher mortality rate than in non-pregnant women. As pregnant women with acute liver failure are nearly always infected with hepatitis E virus infection, the mortality of acute liver failure is dependent upon the overall prognosis of acute liver failure caused by hepatitis E virus infection, which certainly is better than the non-E group. Clinical profile of acute liver failure during pregnancy has been carefully studied by us and others. Acute liver failure in this population is an explosive disease with short pre-encephalopathy period than acute liver failure in non-pregnant women. These patients have rapid development of severe encephalopathy and more often present with features of cerebral edema and cerebellar coning. However, high occurrence of disseminated intravascular coagulation was a most distinctive feature of acute liver failure during pregnancy in Kashmir. Of course, as discussed in the earlier studies, mortality in viral hepatitis E related to acute liver failure in pregnancy is less than acute liver failure in non-pregnant women. Why should pregnant women with hepatitis E have such a devastating clinical course? Of course, immunological mechanism causing enhanced liver injury is first to be explored. A shift of Th1 to Th2 balance towards a shift to Th2 response in pregnant women with hepatitis E viral infection, but not in non-pregnant women with hepatitis E virus infection, may point towards a primary immunological cause of severe liver disease in pregnancy. Also, hormones of pregnancy, especially estrogens and progesterones, might impair cellular immunity by triggering a adopter protein, namely ORF3, which could facilitate viral replication and lead to release of cytokines and liver cell apoptosis. However, since the mechanism of liver cell injury in hepatitis E remains mostly unknown, it's difficult to ascribe the severity of liver injury in these patients to these immunological phenomena. We and several others have compared demographic, nutritional, and obstetric and biochemical features of mothers with acute liver failure to those with non-fulminant disease and found no significant difference between the two groups. All these patients are infected with genotype 1, and viral load and duration of viremia has been similar in the two groups. Thus, there seems to be no obvious risk factor in host or in the agent which could cause such a devastating liver injury in pregnancy. An interesting report on the maternal and fetal outcome of pregnant women in hepatitis C virus infection was published from New Delhi. Overall, perinatal mortality during hepatitis C virus infection in pregnant women was 65.4%, being 22% in non-fulminant disease and 100% in patients with fulminant disease. Abortions, stillbirths, and neonatal deaths were common in hepatitis E virus infected pregnant women. 19 mothers with acute liver failure died prior to delivery. Perinatal mortality was higher in mothers with hepatitis C virus infection when compared to those with hepatitis B virus infection. Why should fetuses and babies born to hepatitis E virus infected mothers have such a mortality? Such an outcome of hepatitis E virus infected mothers has been extensively studied by our group by documenting vertical transmission of hepatitis E virus. In 1995, we published a short report in Lancet documenting vertical transmission of hepatitis E virus infection in 5 of the 8 mothers studied. Recently, we have extended these data further to define the significance of these findings. We prospectively studied 26 women with hepatitis E virus infection, 15 with acute liver failure, and 11 with non-fulminant disease. 5 mothers died undelivered, 2 had aborted, 4 had premature delivery, and 17 delivered full-term babies. 15, that's nearly 80% of the 19 babies had evidence of hepatitis E virus infection at birth, which was documented by either IgM antibody to hepatitis E virus in 12 and viremia in 10. 7 babies had icteric hepatitis, 5 had anicteric hepatitis, and 3 had jaundice with normal liver enzymes. 7 babies died in the first week of birth. Prematurity was the cause in 1, and a liver failure in 6. 5 of the 6 babies who died were born to mothers with acute liver failure, again suggesting that patients with acute liver failure give birth to babies with severe liver disease. There are a number of studies documenting vertical transmission of hepatitis E virus to fetuses and babies with poor perinatal outcome. Recently, we wanted to study a provocative hypothesis entitled, could severe fetal hepatitis E virus infection be the possible cause of increased severity of hepatitis E virus infection in the mothers, which may represent another example of the mirror syndrome in pregnancy. For this, we prospectively studied 36 pregnant women with hepatitis E virus infection and their 36 expectant delivered products, that nearly babies or fetuses. We carefully compared the maternal and fetal events to define a possible relationship of the severity of maternal and fetal disease. Babies born to mothers with fulminant versus those with non-fulminant hepatitis were more often hepatitis E virus infected, were more often viremic, were born more often with acute liver failure, and had higher liver enzymes. Thus, there was a close relationship between severity of hepatitis E virus infection in the mother and in the babies. The severe fetal disease could be the cause or the effect of severe maternal disease. Further analysis of the pattern of disease in the babies born to mothers with fulminant hepatic failure who died versus those who survived revealed some interesting observations. 10 mothers who died delivered babies from 5 to 14 days after the onset of coma. In contrast, 6 mothers who survived delivered babies from 1 to 4 days after the onset of coma. Thus, mothers who delivered babies early on expectant basis survived and had rapid clinical recovery from fulminant hepatic failure. This pointed to the dangers of long gestational period after onset of coma. In addition, DIC was limited to mothers who delivered babies with fulminant hepatic failure and not in those who delivered normal babies or babies with non-fulminant hepatitis E virus infection. This led us to believe that fetuses with severe disease, hepatitis, caused by vertically transmitted hepatitis E virus infection may be related to the outcome of fulminant hepatic failure in the mothers. This relationship may be akin to what happens in mirror syndrome, in which mother develops generalized anasarca subsequent to fetal or placental edema. The possible mechanism of increased severity of liver disease in the mothers may be due to production of toxic metabolites in the fetus with fulminant hepatic failure. Such toxin can cross over to the maternal blood and precipitate onset of hepatic encephalopathy and possibly DIC in the mother with hepatitis E virus infection. Such a mechanism has been well established. Pathogenesis of acute fatty liver of pregnancy, in which fetus is homozygous for long chain 3-hydroxylazide coenzyme dehydrogenase deficiency and produces large amounts of toxic omega fatty acids which cross over to the maternal blood and cause acute fatty liver of pregnancy. Further studies are needed to substantiate this hypothesis. Severity of fetal disease in utero can be assessed by examination of the amniotic fluid or fetal blood sampling and correlated with maternal disease. Mechanism by which fetal hepatitis E virus infections can affect maternal hepatitis E virus disease needs to be studied. Randomized trials or studies between immediate termination of pregnancy and expectant approach about delivery are urgently needed to assess their effect on the outcome of the mother. Up till now, clinicians have believed that immediate termination of pregnancy may add additional stress to the mother and lead to higher mortality in acute liver failure in pregnancy. However, these data are not substantiated by any randomized trials. Thank you for your patient hearing.